out these means of intracameral medications, which may be ringer's lactate, BSS, Gylocard, Adaline, pilocarpine, viscoelastic, and their osmolarity, whether it matches with the aqueous or not, their concentration, their pH, and if they are denatured by any chance, they can cause severe inflammation. And then the instruments and equipments may have certain residue, like many of them clean with the enzymes or ultrasonic cleaners or detergent if used to clean the instruments. Phaco tube, if you are using again and again, there may be leftover residual matter because it is to be washed with the distilled water, not with the saline, because it may get deposited over there, then flush it with the air so that there is no water left inside. And IOLs are sliced with the ETO, sometimes there may be ETO over there. And if they are liquid containers, there may be some chemicals over there. And residue of polishing, now we do not see uveitic hyphema glaucoma syndrome, UHG syndrome. It was supposed to be when you polish the lens, some of the residue are not washed and they remain and keep on irritating. This is how patient keeps on getting uveitis, is a very common. So in a lathe cut lenses where you cut it and some of the dust remains onto the haptic and optic of the lens. Then the fibers and preservatives which go inside the eye, all of these can lead to a lot of inflammation inside the eye. So once we talk of the prevention of the post-op inflammation, what we need to do pre-operatively, of course, as we talked, we need to screen for the high-risk patients, how to handle the intraoperative, how to handle your surgery, and what to do in post-operative phase. So pre-operatively, anti-glaucoma medications, particularly prostaglandins, should be stopped 2 weeks prior, though there are few studies which say that you can go ahead and do the surgery, but majority of the people agree that the prostaglandins should be stopped 2 weeks prior to surgery because of the increased incidence of CME if you continue to use the prostaglandin. And if there is a dry eye, it is better. Ocular surface disease should be managed 2 to 3 weeks prior to doing surgery. Your patient will be post-operatively much less inflammation and much more comfortable. Diabetes should be very well controlled. If the patient has got uncontrolled diabetes, there are high chances of inflammation. And if the uveitis is there, for 3 months, patient should have no reaction. So in a uveitis, you can use the topical if there's a healed uveitis and there's nothing else. Quiet eye. So to topical NSAID steroids for 3 to 7 days prior to surgery, even if it is quiet. It's better to have a quiet eye for 3 months. Particularly in anterior non-gallinomatous uveitis and Fuchs heterochromtic uveitis, you don't need a very long preoperative treatment. And if it is a healed anterior granulomatous uveitis, intermediate uveitis, posterior uveitis, patients juvenile rheumatoid arthritis, probably you should start 1 week prior to the surgery systemic steroids in these patients, even if the eye is quiet. So we need to operate on a quiet eye. Very rarely we operate on an eye which is not quiet, but sometimes you might have to. When I was coming to this conference, I got a patient who had a 40-50 pressure and a uveitis on a maximal medication, Diamox, getting intermittent mannitol, and of course we don't know what to do now. So you don't want to operate, you don't want to do trabeclectomy when the uveitis is there. You don't know whether it is because of the steroid, whether it's because of the thick fluid, or it's a primary open-angle glaucoma. So then I advise the patient will do trabeclectomy and inject Ozurdex at the same time. So many times if the inflammation is not subsiding, patient has got developed a cataract in both the eyes and keeps on coming to you for 3 months, 6 months, you have waited. So then Ozurdex or Triamcinolone intracameral below the iris or even subcutaneous really works very well. And then of course the surgical skill is the key. Minimally invasive, we give a small incision, but if your knife is blunt, actually it may cause a lot more damage. So anytime you see the whiteness around the incision, that means your knife is blunt actually. So if it is a smooth knife, you won't be able to make out whether the incision has been made or not. So if you see the white area on both the sides of the incision, that means it was really tearing it rather than cutting it. And tissue handling, so avoid touching iris and cornea with the instruments and a nuclear fragment. Iris should be avoided. I mean, anytime you feel, it should be usually be approximately a millimeter or so, either in depth or horizontally away from it. Like suppose you're operating a small pupil phaco, then even if you're deeper to the iris, it won't cause so much of a trauma as if you go and touch the iris. Chamber fluctuation is, to my mind, is the most important component of causing inflammation. So chamber fluctuation should be avoided at all costs. That means your incision should be properly made. And when you are withdrawing your phaco probe, if you inject slight amount of viscoelastic from the side port, chamber will not collapse. And even if you are not putting a viscoelastic, so first you stop the irrigation, wait for some time. When the pressure is, bottle height is 100 millimeter of mercury, if you withdraw suddenly, the chamber collapses suddenly. Let the IOP be little less, let the chamber be little shallow or mildly shallow, and slowly withdraw your probe, chamber will not collapse. So same I do when I do irrigation aspiration, I put the lens, now I'm removing the viscoelastic, or if I have done a hydroimplantation, I ask my assistant to lower the bottle height to 40 or 30 centimeter instead of 100 centimeter which was there, and then slowly I withdraw so that there is no sudden collapse of the chamber, everything bulges out. And phaco energy, of course, we need to use the minimum phaco energy. Cortex and lenticular material, there should be no residual cortex lenticular material, there should be no viscoelastic left, and wound closure is the key actually. Whenever, and particularly my side wound incision leaks more than the main port incision. Reason for that is because in a main port there is a silicone sleeve covering the phaco probe, so the ovalization of the main port incision is not there. But side port incision, because there is no silicone sleeve and you're putting a rounded instrument from that side which is very tight, so it makes the incision slightly oval. So I usually, after doing the surgery, I exchange the fluid with the air, and even if the fluid is there, I press the side port incision for 1 minute and you will see that it starts leaking the fluid. Because many times the task which takes place, the inflammation takes place, because when the chamber collapses, some of the fluid gets sucked in, what is called the ingress of the fluid. If the bacteria go in, it will cause endophthalmitis. If the unsterile material goes in, lipid and other things, it may cause severe inflammation and a task. So the incision closure is the key, and under no circumstances should leave a leaking wound. So post-operative treatment will, topical steroids are the potent pacifier, we all know, and all of them are actually work very well. And loteprednol is that way causes less rise of IOP. So this should be preferred over that, but if you feel it is not responding so well, then you can shift over to dexamethasone, which is the most potent of all of them. And of course the ketorolac, diclofenac, bromophenate, enaphanic, all of them are very good. And actually incidence of CME is much less with an NSAID than with these steroids. So the NSAID can be started pre-operatively 1 day prior to the surgery and post-operatively, but this all standalone, they may not be sufficient, and you need to give the steroids. The only question is that NSAID should not be used if there is a poor epithelium. It causes more dry eye, as preservative can cause damage. And Triamcinolone Acetonide, I did just one study, we are not published. There is a lot of reports where they can give for subcutaneous 40 milligram. But what I found, even 1 milligram is good enough actually. You don't have to. 0.01 ml if you give the Triamcinolone at a subcutaneous. I had my own technique. I put on a wire vectors over there and inject a small amount. If there's any time IOP raise, you just lift it and cut it. So you can give, actually in all the cases where inflammation will be there, subcutaneous Triamcinolone can be given very effectively. Intracameral can also be given behind the iris. So most of the time, what is our regimen for that is, so steroids 4 to 6 times for 1 week, then 2 to 4 times second week, and 2 times per day third week. NSAID are started along with that, which continues for 6 to 8 weeks, while the steroids are tapered off in 3 weeks' time. Follow-up, of course, you need to have, and you need to monitor the patient's discomfort, sadness, cells and flare, and any vision diminution and distortion. The key point, if patient has got a diminution of vision, check on an amsylogate. If there is a distortion, you are sure that patient is having a CME, and get an OCT done, and follow it up on the OCT whether this is going down or not. So the toxic anterior segment syndrome, TAS, I thought the one who will be covering, mathematics will be covering. But we need to understand that this is far more severe condition, can cause endothelial damage, but at the same time is very well manageable by the steroids. So timings, when you try to compare, Lalit, you will be comparing the TOS and abnormalities. So I leave it over here, and thank you very much for your kind attention.
Thank you, Dr. Harbansh. Any questions regarding this? It's very well documented, and one question that you have shown the two options using triamcinolone in a Uveitis or Uveitis cases. One is intracameral, another is a subconjunctival. So intracameral lasts longer or subconjunctival lasts longer in this case? And what are the chances of rise IOP in either case?
See, the triamcinolone I used subconjunctival in my 60 patients. There was no rise of IOP because I used only low doses. Initially, I gave the protocol of 0.5 ml, then I found that was not required. So this was a thesis topic, and I prefer Ajudex over anything else a patient can afford. It was a very slow release, very long acting, and causes no floaters, nothing. So I usually will not prefer, if of course the patient is not able to afford, and then you can go with the triamcinolone, but I'll prefer triamcinolone to be subtenon and subconjunctival instead of putting intracameral, and Ajudex inside the eye. So I'll usually avoid putting triamcinolone inside the eye.
Sir, in your case, means in such cases, when there is acute and severe inflammation, no infection, the posterior capsule is going to get opaque. Now it's only 1 month or 2 months. Would you advise YAG at that time, or would you like to wait and explain the patient?
I think the opacification has to be monitored actually, not to do the YAG out
the
of the
patient,
that
before patient comes to you is already severely inflamed.
See, the chances of an inflamed eye, any intraocular procedure should be avoided as far as possible, and even the YAG capsulotomy, because if they're associated with CME or something. So normally I will not do YAG capsulotomy 3 months after the surgery. I'll minimum wait for 3 months. I don't think really in 1 month's time it is going to be so hardened that you can't wait for 2 months more. So even if the inflammation is there, I will like to wait for 3 months before I do the YAG.
And what important points do you cover when you have pre-operatively, suppose you suspect that these patients have post-operative inflammation? What important points you cover in your counseling with these patients?
See, the only, I think if you tell the patients that it may take little longer than usual, because whenever we do the surgery, its inflammation to the eye takes time to settle down. कभी कभी तो हम भी कहते हैं घर में बहू आती है तो उसको भी एडजस्ट करने में टाइम लगता है तो तुम्हारे आँख के अंदर लेंस जा रहा है तो थोड़ा सा टाइम लगेगा इसको एडजस्ट करने में. So it will take 6 to 12 weeks for it lens to settle down in your eye.